Hello, we are now going to see the second part of the topic on hypothalamo-chiasmatic pathway gliomas. The second part is dedicated to the surgical management of these tumors. So what are the aims of surgery for these tumors? First, it is to obtain histopathological diagnosis, which is not necessary for patients with NF1, as we have seen before. It can be decompression when there is a cyst or a hematoma, or tumor debulking, especially in case of hydrocephalus, as we shall say. The treatment of hydrocephalus may need to do a ventricular disobstruction with tumor removal, or to drain, because ventricular cystinostomy is generally not possible unless you do some tumor resection. And tumor reduction can sometimes reach to total resection, but it's very rare because most of these tumors are infiltrative. So it happens mostly in an optic pathway, in an optic nerve glioma, and sometimes in third ventricular tumors. So hydrocephalus, how do we manage it? It can be caused by ventricular obstruction, but also sometimes by extraventricular obstruction when there is a arachnoidal seeding of the tumor. Or it can happen after surgery because these are often infants who develop subdural collections after surgery. So how do we manage hydrocephalus? ETV is generally not possible. We can use an EVD, for example, in emergency in case of intratumoral bleeding, but that means that we have a plan to do open surgery after EVD, because EVD itself will not cure the hydrocephalus, or we put an EVD after tumor resection with a ventricular approach. We do VP shunts by default when we cannot do other way, when it's unavailable. We do VP shunt as less as possible because these valves are especially prone to obstruction because of bleeding, because of the protein secretion by the tumor. And we can treat hydrocephalus by tumor debulking. And the illustration below shows a large chiasmatoventricular tumor in a child who became a teenager who developed a lot of repeated shunt obstruction, which were very badly tolerated, with coma, with vision loss. And in the end, we did a tumor resection, which was satisfactory, but subtotal, of course, but then the patient did not need any shunt revision. So in our series, hydrocephalus affects 30% of our patients. 13 had a VP shunt, 7 had an EVD, and 2 a subdural shunt. So this hydrocephalus can be complicated because the fluid is often albuminous. It can cause obstruction, ascites, as shown here on the right, or septation of the hydrocephalus. In fact, ascites was a classical complication before the time when chemotherapies were developed. But since these patients are given chemotherapy, they very rarely develop an ascites. So this hydrocephalus is especially treacherous because when the shunt blocks, there is a pressure gradient, which can be very badly tolerated. It can even kill the patient. And also, when we operate, these patients are very often immunosuppressed. They show cachexia. They may need a gastrostomy. And the patient on the left had his gastrostomy a few days after shunt insertion, and she developed a meningitis due to Streptococcus D bacterium. And this is the number of shunt revision in the series. A few lucky children had no shunt revision, but most of them had 1 or 2 or 3, even 4 shunt revision. Tumor sampling is another aim of surgery. As said before repeatedly, if there is NF1, it's not necessary to obtain tumor sampling initially. However, it can be necessary secondarily in case the tumor does not respond to the first-line chemo. In other cases, we do an open biopsy or we do a tumor resection, and we get this way the tumor samples. We can do sometimes endoscopic biopsy. However, the tumor samples are very small, and we need bigger and better tumor sample because we need molecular biology studies. And during endoscopy, if we see, if we don't clearly see tumor in the ventricles, if it is white like ependymoma, we should not go for it and rather do an open biopsy of another site. Then a stereotactic biopsy can be used in case of a tumor infiltrating the encephalon or the temporal lobe, but these tumors are very often intermingled with the vessels and the cranial nerves at the skull base, and they are generally not very good candidates for stereotactic biopsy. So what is said by the consensus group in 2013 is that the typical intrinsic optic pathway glioma in association with NF1 do not require biopsy. Then we have the aim of surgery to do surgical resection. We can do very often debulking. It helps to resolve hydrocephalus, as said before, or it helps to obtain an objective response in the same manner as the chemo obtains reduction in tumor volume. In few cases, we can do a total resection, but this is very often a subtotal resection. Total resection is mostly possible in optic nerve tumors, more rarely in tumors of the third ventricle. So before surgery, we evaluate the tumor on the imaging. So where is the tumor? Does it involve the optic chiasm, the third ventricle? In fact, very often we have very big difficulties to identify the optic pathway. And we know they are here because the anterior communicating artery is elevated, but it is very difficult to know if the tumor infiltrates completely the optic pathway, or is there a tumor component which comes out of the optic pathway. The diffusion tensor imaging can be very helpful, but it is not so easily done. Also, we asked the imaging, do we have an idea about the histopathological diagnosis? In general, in pylocytic astrocytomas, we have an intense homogeneous contrast uptake. Spectral MR can help. If we see tumor dissemination, it can be an argument in favor of a more aggressive tumor type like pylomyxoid astrocytoma. And we have to know exactly what is the real extent of the tumor. We have to be very cautious about the injected T1 because contrast uptake can be unreliable. In this case, it looked like a tumor in the thalamus with some cyst. We could envision a tumor resection. However, if we look at the flare, we see that there is a very diffuse infiltration of the optic chiasm, of the hypothalamus, the optic tract. So there was no way we could do a total resection. So then we have to choose the surgical approach. We can use a terminal or subfrontal approach. A ventricular approach can be transcausal or transcortical, or an endoscopic approach to do a ventriculoscopy. Endoscope assisted microsurgery can help, or and more recently, we have been able to do endoscopic resection of these tumors using a dedicated CUSAC, which can be used through the endoscope with some partial but very interesting results as shown here. So the terminal approach, it gives access to the optic tract through the optocarotid space. We see the pituitary stalk. We see the lateral aspect of the optic tract, which is very often impacted by the carotid artery. The tumor bulges on both sides of the carotid. And we can also access the temporal extension of the tumor. If we dissect the anterior cerebral artery, we can access the upper aspect of the optic chiasm, and we can do some resection this way. If we open the Sylvian fissure, it allows us to retract the frontal lobe and more easily expose the optic chiasm. We use an extended subfrontal approach to gain access to the third ventricle through the lamina terminalis, which can sometimes be useful to access tumors which are purely intraventricular above the optic chiasm. The lamina terminalis is thin, avascular. It is enlarged by the tumor, and through it we can do piecemeal resection, debulking and mobilization of the tumor. However, this approach is more suited for craniopharyngiomas than for optic chiasm tumors. So this is the view we have under the chiasm. We can go as far as the basilar artery, and this is the view we can get through the lamina terminalis to the floor of the, on the lateral walls of the anterior hypothalamus. This is an example of a perineal approach with the aim of a biopsy of the tumor involving the optic tract, which is the optic nerve, the internal carotid artery, and the anterior cerebral artery. This is a classical approach that is done for aneurysms, for example. But it was just for a biopsy because the tumor was completely infiltrating the optic tract. This is another approach for patients who had a very big cyst with some intracystic bleeding, with a tumor infiltrating the optic chiasm and the optic tract. It can be useful, especially for cystic tumors, because cysts are not affected by chemo or irradiation, and also they can prevent chemo or irradiation. And this is the operative field after removal of the cyst and partial removal of the tumor. And this is another example of a patient with a very big cyst and a tumor infiltrating which appears to infiltrate the optic tract. When we remove the membrane of the cyst, in C we see the tumor, which is well delimited from the optic tract, and this tumor could be removed very efficiently down to the third ventricle, and with some reshaping of the bone flap to correct the deformity, which was not enough to prevent the child from developing a subdural collection. It was well tolerated, and we see on this imaging that there is very few tumor left, and this child went without a chemo. Then we have the transventricular approach, when the tumor is developed, especially posteriorly, with superior extension, with hydrocephalus. It can be used in emergency. However, this transventricular approach does not give good access to the chiasm and the optic tract, and it is limited anteriorly by the anterior commissure. So which approach do we choose? The transcarousal is more often used because it gives a vertical axis of view. It is preferable to have hydrocephalus to work in a larger space, but it is not mandatory. The obstacle is in the lateral extension of the transcarousal is the pericarousal artery. So the transfrontal approach can be more useful if we have an extension laterally in the lateral ventricle. The locations which are accessed by the transcarousal approach are the Monroe, the third ventricle, and the opposite ventricle. And we have a better access to the homolateral hypothalamus. The blind spot in the transcarousal approach is the anterior commissure, while in the transcarousal approach, transfrontal approach, it is also impaired by the anterior commissure and gives, in my mind, not a good approach to the homolateral hypothalamus. The bilateral access is common in the transcarousal approach, is more awkward in the transfrontal, and redo surgery can be difficult after transcarousal approach because of cortical adherences. And in transfrontal approach, the damage remains homolateral. In our experience, we use the transcarousal approach in most cases, and the transfrontal approach mostly in emergency and very large tumors. So this is the winner. So this is how we do the transversal approach. We do a small flap on the midline, straddling the coronal suture, with a hinge on the anterior part of the sagittal suture. It is possible, but more difficult when the lateral ventricle is of normal size. And we can also dissect the telochoroidea, which is lifted by the tumor. And sometimes we have, it can be also difficult when the fornix is spread over the tumor in the which is in the third ventricle, and we have to reach the lateral limit of the fornix. So in the end, we have the colon of the fornix, which is preserved, and the thalamus striate vein, which can be preserved also, of course. Sometimes we have to extend the approach posteriorly by lifting the choroidal, by opening the choroidal fissure, by lifting the choroid plexus of the lateral ventricle. So this changes the approach from transcarsal to subchoroidal. We elevate the telochoroidea from the thalamus, and it's very important to respect the thalamus striate vein, and it gives access to the posterior third ventricle. And this way we have a tangential approach to the telochoroidea, and it gives access to the pineal region tumor, to the pineal region, and to the aqueduct. What are the tricks and traps of this this interhemispheric approach? When we have corticodural veins, we should prevent them from drying, because there is a risk of tearing, which can be prevented by using chirurgicale and bioglue to prevent these veins from tearing. Sometimes during the approach, we have a giral indentation with adherences between the two hemispheres. So we have to avoid doing a lesion, especially bilateral lesions, to the singular gyrus. When we reach the corpus callosum, we know it because it is white. It is avascular. If it is not the gyrus, it is the cortex. And sometimes you open the corpus callosum and you find yourself in a white desert. That means you are in the fifth ventricle, that is a septal cyst. Ventricular surgery can be tricky, and there are some traps. When you open, when you reach the ventricles, you have to know which side you're on. Is it left? Is it right? So you have to check the imaging before to know where if the septum is shifted to one side or the other. As I said before, sometimes the fornix is tapered over the tumor, so the tumor is not visible. You have to dissect the lateral limit of the fornix to reach the tumor. And once you are in the tumor and you debulk it, you gain a better access. And if you do a contralateral extension, you have to anticipate that you may have two sheets of septal tissue. And if you reoperate, you may have to go through from the other side to avoid the adherences from the first operation. But this may be difficult also, because you finally reach a place where you have adherences between the two singular gyruses. This is an example of a baby who had the encephalic syndrome, who arrived comatose with a big tumor on the hydrocephalus. And this is, we did a transcarsal approach, and we removed part of the tumor, but not all of it. And the rest of the tumor could be treated with chemo, but the child improved much after surgery. Optic nerve tumors, we have to decide when we should operate. We operate when the tumor progresses, especially if the child is blind or almost blind. There is no use of keeping a vision of 1 in 20 if the child is painful or the tumor is growing. So it's better to remove it. Another indication is when the child has pain or has exophthalmos, especially if the cornea is exposed. And so we can discuss the role of chemotherapy if the child is not blind. So these are a picture of an observation of a child who had a loss of vision, almost complete, with some exophthalmos, and the tumor could be approached through a palpebral incision and removal of the optic rim, of the rim of the orbit, which gave access to the superior and lateral aspect of the orbit, and en bloc resection of the tumor. And the eyelid is heals very beautifully, as you can see in this image, where the scar is invisible. This is another case of an optic tumor which had an extension in the cisterns, but it did not reach the chiasm, so we were not afraid of aggravating her vision. She had some exophthalmos, she had some pain, and the tumor was approached with a Ternary Approach, with a bone flap, removing the rim of the orbit on the same side and on the roof of the orbit, giving access for extradural and intradural control of the tumor in the orbit and in the cisterns, and the tumor was removed en bloc. Reoperations may be necessary. We may need new biopsy. For example, when the tumor progresses after irradiation, we have to make sure that there is no degeneration of the tumor, or we may need to do a new resection when the tumor grows, or if there is a new tumor, for example, in NF1, or if there is a radio-induced tumors, or we have to reoperate for shunting or shunt revision. And so among our series, a majority of patients had no surgery. A smaller group had one surgery, and some unlucky children had 2, 3, or even up to 7 surgeries during the follow-up of their tumors. So is resection associated with better outcomes? The answer is no. As we can see, it looks like the event-free survival is better for tumor when the tumor is resected. However, we have to remind that we are operating different patients. If we don't operate, the outcome is often better because these patients have very often NF1. So surgery is indicated in bulky and aggressive tumors, and not indicated in NF1, which are much less aggressive tumors. So in conclusion, surgery is an indispensable adjunct to surgery. It is indicated in emergency because of hydrocephalus, because of bleeding. It is needed to obtain tumor sampling, to do tumor debulking when the tumor is big and when there is hydrocephalus. It may require reoperations, and total removal is possible in only a minority of tumors, mostly of the optic nerve. I thank you for your attention. If you want more information, you can get it on the Anglais website, and you can also watch our other videos online on YouTube.